Dyselectrolytemia. And we'll be focusing about mainly sodium and potassium. So when we talk about electrolytes, we can even think about calcium and magnesium. We'll cover them subsequently, but today our focus is mainly on sodium and potassium, and a lot of these endocrine issues are there. Dyselectrolytemia can impact the outcome of a particular individual, both in terms of etiology, pathology, and evaluation and management, and that's what we'll discuss. So we'll start off with this 14-year-old boy who presented with drowsiness, was found to be euvolemic clinically, was found to have low sodium levels with a high urinary sodium. So he had hyponatremia, dilute serum, and dilute urine. So somebody thought this is more likely to be a SIADH picture, was advised fluid restriction. So as we know that the most common cause of euvolemic hyponatremia is actually syndrome of inappropriate ADH secretion, but this child actually worsened once the restriction was done, and further evaluation showed that this child actually had a central hypothyroidism and cortisol deficiency. So a lot of these endocrine issues need to be considered before we label any particular individual as a condition. Otherwise, there could be a significant impact with regards to clinical perspective and evaluation. All of you can go through and learn more with regards to pediatric endocrinology from our master course in pediatric endocrinology, which is available in the website. And we'll be using many of these approach pathways and management pathways today of our app to see how we can easily evaluate and manage this condition. So we'll start off basically with the initial physiology of electrolytes, and we really understand that electrolyte distribution in a cell and extracellular environment is specific for different ions. So there are potassium ions which are predominantly intracellular. So a lot of this store of potassium is actually inside the cells, and migration from or to the cells can cause a lot of changes in potassium, and this we'll discuss. While we have got sodium, which is predominantly extracellular ion, and this is the main determinants of tonicity of the blood. And when we talk about tonicity, it is the capacity to retain the fluid which is there with that. Now, this active gradient of sodium, which is 14 times in terms of the extracellular sodium, and potassium, which is 40 times compared to the extracellular, is maintained very actively via an energy-dependent process, which is the sodium-potassium ATPase. It pushes sodium out and pushes potassium in, and this is regulated by a number of things like insulin. So conditions associated with insulin deficiency are associated with reduced sodium-potassium ATPase action, and potassium shifts outside. Once we give treatment for that, like DKA, this potassium will go in and cause hypokalaemia. The second condition could be that if somebody is recovering from malnutrition, like anorexia nervosa, or if somebody is on a severe acute malnutrition, you suddenly build up their nutritional status, you will see this potassium shifting in, and that will cause real hypokalaemia, and we need to be bothered about that in that perspective. Similarly, beta agonists will cause this potassium to go in, and this is used as a therapeutic measure in treatment of hyperkalemia. Now, the other major extracellular ion is chloride, which is essentially responsible for the electroneutrality, and there is very little chloride in the cells. Bicarb is, of course, there. So this difference of sodium from chloride and bicarb pretty much means is the difference of the positive ion, the measurable positive ion, from the measurable negative ion, tells us about the anion gap in this perspective. So when we talk about measurable anions, we are basically talking about sodium, chloride, and bicarb. And the difference between the two basically is the various proteins, the anions, are there which are present, and this is known as anion gap. Conditions associated with increased anion gap would mean that we have got negative ions other than chloride and bicarb, which are basically getting accumulated in the form of organic acid, lactic acid, ketoacidosis. While if anion gap is normal, it is either because of decrease of bicarb or increase in chloride levels. So we have got normal anion gap versus an increased anion gap metabolic acidosis based upon this perspective. Now, there is also protons which are there inside. Calcium, again, is one which is basically largely in the extracellular region. There is some calcium inside, but that's usually bound to a specific content in that perspective. We are not going to talk about phosphorus and magnesium now. So when we're talking about this discussion, we are mainly focusing upon sodium and potassium. And the major determinant of tonicity in the body is actually the sodium level. And the sodium concentration will depend upon two things. How much is your sodium and how much is the fluid volume. So sodium and water are the key determinants of sodium level, tonicity, osmolality, whatever you want to think of in that perspective. Now, the major ways in which we regulate them is the intake. So if we talk about water, we are talking about thirst and intake via the gastrointestinal tract and the urine output. So major abnormalities in sodium homeostasis are actually because of water imbalances rather than sodium imbalances. So if we talk about hypernatremia, it is mainly because of decrease in free water. While if you talk about hyponatremia, it is because of excess amount of free water. You can have hyponatremia, which is partially because of salt wasting, but even there, as we'll discuss subsequently, there would be an increased AVP effect, which is appropriate, and that will further cause water absorption, resulting in dilutional hyponatremia. So the major problem in sodium disorder is actually at the level of fluid and not at the level of sodium. And now if you think about it, the major cause of hyponatremia is SIADH, and the major cause of hypernatremia is basically in the setting of a diabetes insipidus. So when you talk about that, AVP becomes much more important in terms of regulation. Now, in conditions where there is an increased tonicity in the body, this is sensed by the specific organs in the hypothalamus, the organ vasculosum, lamina terminalis, OVLT, and the subfornical organ. And from there, body will produce greater amount of vasopressin. And this vasopressin is basically going to then concentrate the urine. So the urinary excretion of water becomes less. There is less amount of water in the urine. So if you have more water in that perspective there in the blood, and that is going to correct the osmolality in that system. Now, conditions associated with decreased volume will then trigger off a second pathway. So we have talked about the effect in terms of tonicity. What about volume? So if volume comes low, there is a potent stimulus of the renin, angiotensin, aldosterone system, which will then cause the sodium excretion to go down and potassium excretion to go up. So hypovolemia will trigger RAAS system, will cause retention of sodium and loss of potassium, causing, so to speak, hypernatremia and hypokalaemia. Now, if you have a defect anywhere in the renin, angiotensin, aldosterone system, you will have hyponatremia and hyperkalemia, which will be observed in this setting. Now, you also need to understand is that this volume stimulus also stimulates AVP. The responsiveness of AVP for a given osmolar level actually increases if there is hypovolemia. So any condition which causes hypovolemia, like if you talk about aldosterone deficiency, will ultimately trigger AVP, will cause fluid to come in, will cause dilutional hyponatremia in that perspective. So AVP excess, whether it is appropriate or inappropriate, is a major driving force with regards to the regulation of serum sodium level and hyponatremia. So hyponatremia to be sustained requires a AVP excess in this perspective. Now, if the volume goes really high, we've talked about two systems till now, the AVP and the RAAS system. There is then triggering of the natriuretic peptide system, which will basically cause natriuresis and also inhibit the RAAS axis by inhibiting aldosterone. So these three mechanisms in a way are able to maintain the levels prospectively. AVP is largely for tone, RAAS is largely for volume, ANP is actually antagonistic of volume. What this tells us that if we are having more RAAS activity, aldosterone excess, sodium goes high, you will then secrete this ANP, causing this natriuresis, and ultimately there will be no hypernatremia in that setting. So RAAS excess states are not associated with hypernatremia. They basically present with hypokalemic metabolic alkalosis because of the aldosterone excess in that perspective. Now, this potassium will go into the cell with the sodium potassium ATPase that we have discussed earlier. So conditions which are associated with the RAAS excess will cause increased urinary loss of potassium via the aldosterone effect, and they will also shift it into the cells, causing severe hypokalemia along with metabolic alkalosis. As discussed, insulin will also have an impact here, as are alpha and beta agonists, which will cause an impact there. Now, AVP action is actually inhibited by cortisol. So cortisol basically has multiple effects on fluid excretion. It inhibits AVP release and AVP action. So cortisol deficiency would therefore result in a state which will behave like a AVP excess, and therefore any individual with euvolemic SIADH cortisol deficiency has to be excluded in that situation and perspective. Having got through the entire pathway, we should just focus on how the kidneys are regulated, because a lot of this endocrine regulation happens in the kidneys. So sodium is basically filtered by the glomeruli. Most of it is absorbed at the level of the proximal convoluted tubule. This is a passive process. But the only regulated absorption of around 2% sodium actually happens at the level of collecting duct. And this 1% remaining is actually excreted. Now, this absorption is done via the epithelial sodium chloride channel, where you have the aldosterone acting, and therefore aldosterone has a predominant effect on the epithelial sodium chloride channel. Now, along with the sodium, chloride also moves out from the lumen, but its speed is less, and because of the less speed, there would be a electronegativity which is there in the lumen. So lumen becomes electronegative as compared to the circulation. To compensate that, a lot of these positive ions will then be shifted out in the form of potassium and proton. So the basic role of epithelial sodium chloride channel is to take in sodium chloride and push proton and potassium. So if this is hyperactive in the setting of Little syndrome, or because of increased mineralocorticoid receptor action, or because of increased aldosterone action, you will have hypernatremia, hypokalaemia, and metabolic alkalosis. This hypernatremia will go off in a couple of days. There will be no edema, because then the natriuretic peptide will really come into the picture and it will control that. Now, we know that renin is basically produced by the kidneys, the juxtagranular apparatus, under the influence of hyperkalemia and hypovolemia, which converts angiotensinogen to angiotensin 1, which is then converted to ANG2, and which controls the aldosterone secretion. So this is the whole renin angiotensin aldosterone pathway which regulates that. Excess RAAS pathway causes hypokalemia and alkalosis. RAAS deficiency will cause hyponatremia with hyperkalemia and metabolic acidosis. Remember, this will also result in hypovolemia, trigger AVP. So there will be a secondary dilutional hyponatremia, which will be an important part to consider in this perspective that we need to understand. So if we are giving too much sodium, the body will react, causing hypokalemic alkalosis and increased urine sodium. Anybody who has hypernatremia should have a urine sodium more than 25. Similarly, if the sodium load is less, there would be a hyperkalemic acidosis, and the urinary sodium should be less than 25. Hyponatremia with high urinary sodium means that there is a urinary loss of sodium that is happening. Now, renal potassium handling is also very important, and most of it is actually absorbed at the level of proximal tubule. But as discussed, there is a role of sodium-potassium exchange. So the potassium excretion depends upon the amount of sodium which is delivered out here, and the action, of course, of the renin-angiotensin aldosterone system. As sodium goes in, potassium is lost along with proton, and ammonium, which is also responsible for the proton excretion, is there. Now, loop, osmotic, or other forms of diuretic will cause increased sodium delivery here, causing more sodium absorption and potassium loss, and therefore diuretics cause hypokalemia, metabolic alkalosis with mild hyponatremia, which is observed. Similar features occur with tubulopathy like Bartter syndrome or Gentleman syndrome or metabolic alkalosis. Now, aldosterone, as discussed, we've discussed already how this renin-angiotensin aldosterone system works, is a major determinant of this potassium excretion. Increased aldosterone, increased potassium loss, hypokalemia, alkalosis, decreased aldosterone, hyperkalemia, metabolic acidosis is the usual effect. What about water? Most of the water is resorbed again at the level of the proximal convoluted tubule, but the significant endocrine regulation happens at the level of collecting duct, wherein we have the AVP, which acts via the V2 receptor, causing water excretion to be controlled through the aquaporin channels, which are basically stimulated. So defects in aquaporin channel or V2 receptor will result in the setting of nephrogenic DI, wherein there will be loss of a lot of water. There will be hypernatremia. While AVP deficiency will cause central diabetes insipidus, and AVP excess will cause more concentrated urine, resulting in hyponatremia. Now we have discussed about the three major systems, the AVP, the RAAS system, and the ANP, and they all have a good crosstalk between each other. So if the AVP level goes up, you've got more V2 receptor action, the water excretion becomes less, volume will become more, and you will have hyponatremia. Now this hyponatremia and increased volume will then trigger the ANP, and this can further result in natriuresis and suppress aldosterone. So there is a close interaction between aldosterone, AVP, and ANP. AVP and aldosterone increase volume, and they will also act in terms of sodium. Aldosterone will basically cause mainly sodium effect, AVP will cause mainly fluid effect, and ANP will cause sodium loss if it's excessive in this situation. Now, just now to understand what happens if this delicate balance is lost, we need to understand that osmolality and serum sodium are one of the most regulated parts of our entire homeostasis. Even 1%, 2% change will have a huge impact. So in conditions of hyponatremia, the fluid goes inside the cell, causing cell swelling, resulting in acute changes of coma, seizures, and distress. If it's moderate, it will cause nausea, headache, and confusion. While with some time the cells will get adjusted, the osmoles will be taken off, so these osmoles are excluded from the system. So in chronic situation, the condition improves, but the presentation will remain with weakness, cognitive defects, instability, gait, falling frequently. And very important to understand that it's the rate of fall which is more important. So if your sodium level was 140 and becomes 125, you will be more sick. Then it was 125 and becomes 120. So rate and of fall is more important, and that is important that chronic hyponatremia does not need treatment. Why we should be careful in terms of rapid treatment is that if the correction is done very rapidly, basically the cells will shrink, and that will cause huge problem in the form of osmotic disequilibrium syndrome, which was earlier known as central pontine myelolysis. So we need to keep the sodium correction at a very low level in that perspective. Now, hypernatremia is associated basically with exclusion of fluid, causes cell shrinkage, causing altered sensorium, seizures, and hemorrhage. And similarly, with time, this osmoles will go into the cells, they will take care of it. And if suddenly we correct it, we will have problems in terms of cerebral edema. So hyponatremia is associated in the acute state with cerebral edema and shrinkage if we correct rapidly. Hypernatremia basically is associated with shrinkage initially and cerebral edema if we correct it rapidly. Chronic presentations is more with failure to thrive, fever, dehydration for hypernatremia, and weakness, cognitive defect, and instability for in the setting of when we talk about the hyponatremia in that perspective. What about potassium? Potassium plays a very, very important effects in concentration of the urine, cardiac conduction, and contraction of muscles. So hypokalemia is associated with nephrogenic DI causing polyuria, contraction abnormality, and cardiac abnormalities. So hypokalemia, think of nephrogenic DI, arrhythmia, and spasm and paralysis. Hyperkalemia will cause cardiac abnormality and contraction. It will cause arrhythmia and asystole and paralysis. So these are the conditions when we have to think about these situations. So we have discussed in detail with regard to pathophysiology. We will now touch base about how to assess these conditions. So serum sodium should be done any time of the day. There's no problem with that. The only caution is that if somebody had seizures or there's a strenuous exercise, there may be a very high level of sodium, which is temporarily, which may improve. So if you have doubt, do the levels again. False values can be found with abnormalities in protein, lipid, and hypertriglyceridemia, which is known as hyperglycemia, which is basically known as pseudo hypernatremia, and hypoalbuminemia may cause a falsely high level. Very importantly, the normal range is 135 to 145. We should be worried when the levels go below 130 or above 150. Pseudohyponatremia is basically because of abnormalities in sodium measurement in the setting when the solid phase is more. So if it's lipid, glucose, importantly, glucose is very, very important from DKA perspective. For every 100 milligram per DL increase in glucose, the sodium levels basically come down with 1.6. So you have to correct this formula. To do that, that will be a more reliable measure in that perspective, as well as protein. Now, ion selective electrodes, which most of the nodal labs are using, don't have a problem with lipid or protein, but glucose problems are persisting in that perspective. What about potassium? Potassium can be done at any time of the day. And the caution that you have to look at is to avoid hemolysis and syringe because it's an intracellular one. We have to be careful that we should not put a cornique and a sample should ideally not be lying down in the lab for some time. Falsely high values can happen with hemolysis. Low values can happen with storage and with high counts like leukocytosis or even leukemia. Blood gas analyzers tend to have a lower value by 0.4 millimoles per liter, and be careful about a squeeze sample high count in tonicity if the potassium is high. Other thing to remember is that the potassium level depends upon the age group and the maturity of the individual. So there are different criteria which we are there for preterm neonates, for term neonates, infants, childhood, and adults. And what we see that preterm and term neonates tend to have a higher level. So the cutoff for hypokalemia is less and for hyperkalemia is high. And this we already discussed that blood gas analyzers tend to have a lower level. Also remember that metabolic acidosis causes increase in potassium level. For every 0.1 decrease in pH, the potassium level goes up by 0.6 in this situation. Now we've discussed a lot about physiology and assessment. We just need to think about how this interplays. So we've discussed that sodium and potassium usually go the opposite direction. So normally, if you have hypernatremia, you will have hypokalemia. This is a typical situation. This means that there is a RAAS excess. Similarly, if there is hyponatremia, there would be hyperkalemia. This is RAAS deficiency. But there are two paradoxical situations. You can have a situation where you have high sodium and high potassium. This is a very, very rare situation, which is basically in the form of Gordon syndrome. We'll be taking up the questions after we have done the discussion, so to allow the continuity in this perspective. So we'll take it to the end of it. Now, if you have hyponatremia and hypokalemia, it means you're losing this sodium and potassium through either the gut or through the kidney. So this means Bartter, Gitelman, you can add diarrhea and diuretic use. So this combination of sodium and potassium abnormality will give you a clue which way you're looking at. Hypernatremia, hypokalemia, RAAS excess, hyponatremia, hyperkalemia, RAAS deficiency, hypernatremia, hyperkalemia, Gordon syndrome, hyponatremia, hypokalemia, diuretics, Barters, and tubulopathy is what we're looking at in this situation. So we'll go one by one pretty quickly with regards to now we have set the base. We can easily go through the individual conditions. So hyponatremia, basically the presentation depends upon the level, which is absolute, and how much it is falling. So generally till 130, there are no symptoms. Between 150 and 125, there are symptoms of irritability, nausea, and apathy, drowsiness, headache. Seizures happen when there is a rapid fall in this perspective, and you can have cerebral edema, coning, and those symptoms can present. Very importantly, rate of fall is more important as in the setting. So hyponatremia can happen if there is too much fluid or too little sodium. Too much fluid is associated with overhydration. So often clinical parameters are difficult to identify. So I always put emphasis on uric acid levels and PCP. Uric acid is unique in that its urinary excretion is dependent on the volume status. More volume, more excretion, less uric acid. So low uric acid is a very good marker of fluid overload, and this would be indicative of a SIADH-like situation, so to speak, in this setting. They will be U2 hypervolemic, while those who have a sodium depletion will have a high uric acid in PCV. This is to differentiate renal from adrenal. Now, they will of course be dehydrated. So excess could be because of fluid overload, because of cardiac failure, nephrotic syndrome, and CLD. Remember, all of these conditions are effective hypovolemia. So AVP will be more, you will take in more fluid, and you will have hyponatremia. Now, you can have syndrome of inappropriate AVS secretion, but the differential to that, of course, is endocrine defect because of thyroid and cortisol deficiency. RAAS defect can cause hyponatremia along with hyperkalemia, while tubulopathy can cause hyponatremia with hypokalemia along with diuretic use. Cerebral salt wasting is a condition which we don't consider very often, but should be considered if you are having a CNS insult and suddenly somebody is pouring a lot of urine and there is hyponatremia in that perspective. Now, the most important endocrine perspective and the most common chronic cause of hyponatremia is actually SIADH. What basically happens is that normally, as the plasma osmolality goes up, the urine osmolality should go up as well. But in the setting of SIADH, Basically what happens is that this graph is shifted, and there are conditions even at a lower level of osmolality, the plasma osmolality, the urinary osmolality is high. So SIADH is basically a condition associated with dilute blood and a concentrated urine. If the blood is dilute, urine should also be dilute. But this is one condition in which serum is dilute, but the urine is concentrated. So if your osmolality is less than 275, or the sodium level in that perspective is less than 130 and urinary osmolality is high, this is SIADH. You need to have a high urinary sodium. Very importantly, there should be no adrenal, renal, thyroid, or liver dysfunction, because if you have a cortisol deficiency, you'll have a similar picture as seen in the index case to begin with. Now, very importantly, hypovolemia can also cause a shift in this curve. So we need to have a normal volume level and a diuretic use in this perspective. And if you give saline, the sodium should actually be lost in the urine. So SIADH is dilute urine, dilute serum, concentrated urine, normal adrenal, renal, thyroid, liver function, no diuretic use. These are very strict criteria because it is basically otherwise a diagnosis of exclusion in that perspective. So once you have somebody who comes to you with hyponatremia, look for the hydration level. If it is too much, it is free water excess. If it is less, it is sodium loss. Look for pigmentation, for adrenal insufficiency. DSD will suggest 21-hydroxyl deficiency. And if there is micropenis, it is multiple pituitary hormone deficiency. So if you look at uric acid levels are high, suggest a dehydration state, while if the uric acid levels are low, it suggests a fluid overload. Urinary sodium, very important. High urinary sodium with low sodium means that you are having a loss from the kidney, otherwise it's extrarenal. Potassium, if you have hypokalemia with hyponatremia, dealing with diuretic or diarrhea. Hyperkalemia with sodium is a RAAS defect or renal failure. And finally, hemoglobin, again a surrogate marker of hydration. If the hemoglobin is high, it means hemoconcentration. So the key things to look at are urinary sodium and serum potassium, which will give you the clue, and hemoglobin and uric acid are the marker of the hydration status in this perspective. Now, very importantly, neonate with salt wasting would be another situation that you will think of. In that setting, you will look at genitalia. If there is a DSD in a girl, XX DSD, it is either 21-hydroxylase or 3-beta-HSD. If it's XY DSD, it's a star defect. Look at adrenal size. If the adrenal is small in a male, you're dealing with the adrenal hyperplasia congenita. Look at the aldosterone level. If the aldosterone is high, it is pseudo-hypoaldosteronism in this situation. So just to summarize the overall approach to hyponatremia, first of all, rule out pseudo-hyponatremia by measuring blood sugar, lipids, and protein. Look at fluid status. If it's hypervolemic, it is fluid overload. Basically, look at cardiac failure, renal failure, nephrotic syndrome. Euvolemic, look at thyroid and cortisol. If it's normal, it's SIADH. And if it's hypovolemic, look at urinary sodium, which if the urinary sodium is low, we're talking about GI loss. If urinary sodium is high, we're talking about loss from the urine. Look at potassium. If potassium is low, so hyponatremia with hypokalemia with a high urinary sodium suggests tubulopathy or diuretic, while if it is high, it is suggestive of a RAAS defect or a renin aldosterone problem in that setting. So the key evaluation in this situation basically is the fluid status followed by the potassium and the urinary sodium state. We'll go through the algorithm now when we go through the cases. 12-year-old boy with diabetic ketoacidosis, blood sugar is 700, and what we are seeing is that there is hyponatremia. Now, is it really hyponatremia? We have to look at the corrected sodium because its DKA sugar is very high. So we correct for every 100 milligram per DL, you add 1.6. This comes out to be 135.6. So this is not really hyponatremia. It's a pseudo-hyponatremia in this setting. 3-week-old child with failure to thrive and sodium of very low 110. Now remember, if you're talking about an isolated cortisol deficiency or an isolated mineralocorticoid deficiency, you will not have a sodium level which is low. If there is a combined effect, the hyponatremia becomes more because cortisol deficiency will also result in high ABV. We have talked about how cortisol deficiency causes SIADH. If somebody has got combined cortisol and mineralocorticoid effect, the sodium severity will be more. So if I see this sodium of 110, I know this is a combined effect of cortisol and aldosterone. He is not gaining weight, dehydrated, PCV is high. So all features suggest of salt wasting. And so this child is actually, if you look at hypovolemic, urinary sodium is high. This is very, very characteristic, and potassium is very, very high. So this basically, if you look at hypovolemia, high urinary sodium, hyperkalemia, it's a giveaway. And if you look at the clinical picture, this is basically 21 hydroxylase deficiency at this point of time. 1 week old boy with seizures, hyponatremia, and hypokalemia. So now what we're seeing is sodium is not that low and potassium is normal. So aldosterone deficiency is out. There is no dehydration. So we are looking at food status. If the child is actually euvolemic, there is hypoglycemia. So this is another clue. There is a ketotic hypoglycemia with hyponatremia. Now I think if you look at this picture, actually there is a micropenis. So this is a classical picture of hyponatremia. So euvolemic status with cortisol deficiency, and we found this is a multiple pituitary hormone deficiency in this situation. 14-year-old boy with drowsiness and hyponatremia, clinically euvolemic, urinary sodium is high. So you have a child who has a dilute serum and a concentrated urine. Diagnosis as SIADH include restriction, but as we discussed earlier, this child actually had a hormonal deficiency causing the situation. So if we go by our own algorithm, what we see is that there is no hypoglycemia, there is euvolemia. And the next step, of course, is to look at thyroid and the cortisol level, and then we diagnose it as adrenal insufficiency. So it's very, very important to exclude these conditions before we label somebody as SIADH. Now, I won't go much into management. It basically depends upon the symptoms. If it's acute severe symptoms, you can give a 3 to 5 ml per kg, 3% saline over 20 minutes. And infusion can also be given in severe cases. It should only be given to build up to a normal level till the patient is symptomatic. Aim is not to increase by more than 12 millimoles per liter per day. If it's acute moderate, we have to avoid bolus. Rise is less than 6.9. If it's a chronic, we don't give acute treatment, and rise is less than 6 millimoles per liter per day. So there are different ways in which you can treat, and there are the different formulas which are there, which you can use it for correction of dehydration. It often is difficult, confusing. So in our app, you've got the analytic pathway, which talks about how to calculate how much fluid rate is to be given. All you have to do is to put in the weight, the sodium, the desired sodium concentration, rise, and which fluid you want to choose, and you will get the idea. Otherwise, there are these complex formulas which are there with regards to hyponatremia. Now we'll touch base about hypernatremia, which is rare but can be life-threatening. And we know that the symptoms will also depend upon the level of sodium. Beyond 150, 155, we tend to have symptoms mainly initially as irritability. So this is cell shrinkage, duffy skin. So they will not look that dehydrated because the sodium levels are high. Seizures typically beyond 165, drowsiness beyond 165, and coma beyond 170. The most severe form of hypernatremia that I usually have encountered is in the setting of breast milk hypernatremia, which goes up to about 180 and above in that perspective, which is life-threatening. And then you will have hemorrhage, which will happen. Now, again, rate of rise is important. So when do you suspect hypernatremia? If there are seizures, any neurological abnormality, any duffy skin with dehydration, any high-grade fever, which is persistent of chronic hypernatremia. Now, why does hypernatremia happen? If somebody is losing free water, there you will have dehydration, or if there is a sodium gain where there is fluid overload. Majority of causes of hypernatremia are because of free water loss. So hyponatremia is usually because of free water excess and ABP causes. Hypernatremia is again largely because of free water loss and ABP causes in that perspective. Overload is extremely rare in this situation. So you can be reduced intake, extremely unlikely unless somebody's thirst center is gone. Diarrhea and sweating in some newborns can be there, or what we call as a breast milk hypernatremia, in which the amount of breast milk is very less and the patient becomes really dehydrated in that perspective. Now, increased urinary loss can happen because of diabetes insipidus. High RAAS does not cause hypernatremia because ANP will then come in and push off the sodium from that situation. Sodium load very rare. So we are mainly talking about the free water loss, which is the major cause. If you talk about a chronic cause, I would say DI. Acute will be breast milk related. Somebody has prepared ORS incorrectly. Those sort of situations can cause in that perspective. So how do you evaluate? First of all, think of a salt loss, diabetes, osmotic diuresis, mannitol use. If all that is not there, look at urinary osmolality. If the urinary osmolality is less than 600, so if you have a concentrated blood and a dilute urine, it is DI. Do a AVP response. If it's present, it's central. If it's absent, it's nephrogenic DI. If the urinary osmolality is high, which means concentrated blood, concentrated urine, body is doing fine. Look at urinary sodium. If it's low, it's an extra renal loss, GI loss, or maybe osmotic diuresis. If it's high, it's sodium load in that perspective. So basically, you have to look only at urinary osmolality and urinary sodium. And your diagnosis will be done as far as hypernatremia is concerned. Now, water deprivation test is something which a lot of people are getting confused on. That very important. If you already have hypernatremia, don't do a water deprivation test. The aim of the water deprivation test is to ensure that the sodium level goes beyond 143. If you actually have the sodium higher than 146, if the sodium is higher than that, why do we do a water deprivation test? So what you really aim is that as you stop that, you expect the urinary osmolality to increase as the plasma osmolality increases. Because it's already saturated, you won't be able to have any increase if you give further AVP. However, the level remains really low. It means it's DI, and there is some increase, significant increase beyond 50% of baseline. It becomes complete central DI. If there is no increase, it's complete NDI. Sometimes you may have a partial response less than 600. And if you give AVP, there will be no response. It's partial NDI, and some response, it is partial CDI. So urinary osmolality becomes important. You can use urinary specific gravity as a surrogate if that's not available in this situation. So 14-day-old girl with failure to thrive, birth weight was 2600. Now she has lost 300 grams of weight, is exclusively breastfed. Sodium is 182. What is the condition? So we look at the urinary osmolality, which is high. Urinary sodium is high. So this is behaving like a sodium load. But this actually is what we call as breast milk related hypernatremia, typically seen in primary individuals around 3rd week of life who are not feeding well, have decreased urine output. They can become really sick. If not treated properly, they can actually die. So every primary mother, we need to ensure that the weight has regained by 2 weeks and the hydration is normal. This is a very, very challenging condition to treat in this situation. 3-month-old girl with altered sensorium, hypernatremia, potassium is okay, urinary osmolality is low. So there is hypernatremia already and low urinary osmolality. So this is DI, was advised water deprivation test, and this would be catastrophic in this case. So if your sodium is more than 146, please do not do a water deprivation test. It is not required. You look at the AVP response and your diagnosis will be there. 3-month-old girl, such high sodium, I would invariably think of a malformation causing central DI. 5-month-old boy with failure to thrive, fever, recurrent dehydration, high serum sodium, low urinary sodium. This is suggestive of diabetes insipidus. There is no increase post AVP. So this is a classical case of nephrogenic DI. There is a family history in the maternal uncle. There is polyamnios. So this was a vasopressin receptor defect. The nephrogenic DI typically presents as a chronic presentation because you are able to drink a lot of water, but if you're not able to drink, there will be mild hypernatremia, fever, dehydration, and there will be failure to thrive and calcification, which will happen in that setting. 3-year-old boy with polyuria, sodium of 154, and what you're seeing, urinary osmolality is low. So this is again DI. There is a AVP response, which is not very, which is there around 120. So it's like around 7%, 70% increases happen. So the central DI on this cell actually has seborrhea, rash, and lytic lesion. So this is histiocytosis. So histiocytosis should be considered in somebody who has a diabetes insipidus with rash, seborrhea, and an early onset in this situation. 13-year-old boy with encephalitis on ventilator. Polyuria was present. Sodium is very, very high. Urinary sodium is on the lower side. So urinary osmolality is low. So this is again diabetes insipidus. Post AVP, there is some increase. There is increase in osmolality. So this is a classical presentation of brain death DI because the AVP neurons are very widely situated. It would usually be not associated in that sense unless there is a diffuse damage. So if you have somebody who is very sick on ventilator, suddenly pours a lot of urine, it's a brain death DI. which you have to think of, and we can manage them with either AVP infusion or fluid-only therapy. Now, management of hyponatremia depends upon the typical onset, duration, chronicity. Period is typically 48 hours. In acute cases, we can decrease the levels by 9 to 12 millimoles per liter per day. In chronic cases, maybe 6 to 9. The calculation for free water deficit, maintenance, and ongoing losses, and there are standard protocol which is there. And ideally, if possible, we should have an oral correction. Sodium levels is typically 70 to 100. 120% maintenance in your formula would be right in that case. If the sodium level is very high, think of early dialysis, which is very important. So there are ways you can calculate that. You can keep a picture of that. We also developed in our app a way in which you can easily correct it. You just put in the level of serum sodium, how much you want to rise, and the guidelines are also there, and the fluid you want to use, and you will be able to get the formula for there. So now we have discussed extensively about the sodium disorders. We'll just take a few questions, and then we'll try to go forward from there. So Dr. Naresh is asking about, is new method of isoelectric focusing used for measuring sodium also gives false results with hypertension? No, the isoelectric electrodes only have a problem with glucose. Dr. Divyalakshmi is asking, was there a difference in the potassium level according to age? Yes, and as we discussed, the highest level are in the preterm infants, and then the levels tend to go down. Dr. Naresh also asking how much uric acid should be expected with dehydration. Usually it should be more than 6 to 8. In SIADH, we have seen uric acid levels very low, 1 or 2. So this is a very good test in that perspective. If we can get severe hyponatremia associated with hypothyroidism or hypocortisolism, no, we can get hyponatremia, not hyponatremia in that setting. And that's for hypocortisolism, it will be like 120, 125, for hypothyroidism, 125 or so. If routine electrolyte measure can measure urine electrolyte levels, yes, you can use the urinary machine to get that level. Can we use all principles of sodium physiology even in newborn babies, or we need to be cautious about it as the kidneys are still maturing? Of course, Nikhil, we have to look at in terms of the prematurity, the gestation, the systemic effects, and a lot of those factors are there. But many of these measures are pretty similar in that perspective. So you may have different cutoffs which are there for electrolyte levels, for urinary electrolyte levels, but many of these physiology will work. And of course, prematurity has to be thought of in that perspective. So you asked a very interesting question from Deepak is what body preserve perceives regarding sodium measured or corrected. So actually the tonic effect is mainly related through the actual corrected sodium. So when you want to maintain that, the corrected sodium becomes important, because then whatever fall is happening with glucose, you're taking care of it. So you have to take both glucose and sodium into consideration. And if you want to look at one measure, the corrected sodium will be important in that situation to look at. So I think we have taken a lot of discussion with regards to that. We will now move forward quickly about potassium disorders, which are often because of non-endocrine issues as well. Sodium is usually endocrine, hyponatremia because of AVP excess or aldosterone deficiency, hypernatremia because of AVP deficiency, but hypokalemia and hyperkalemia, there are other causes as well. So the symptoms of hypokalemia will start depending upon the level of potassium. So if the potassium level goes below 3, typically polyuria starts. Muscle weakness typically starts around 2.5. So weakness, ileus spasm, there could be a complete paralysis which can happen. And you can also have rhabdomyolysis in this perspective. Cardiac effects happen typically below 2.52 when these symptoms start to happen. Why does hypokalemia happen? You can have an intracellular shift, as we discussed, because of insulin or alkalosis, beta agonist or chloroquine therapy. Some of those channelopathies can cause that. There could be an intestinal loss, particularly with diarrhea and vomiting and NG aspiration. The endocrine causes are largely because of the renal issues. Now, what we need to understand is that the endocrine abnormalities typically are because of the aldosterone excess. As discussed, sustained hyponatremia will happen only if the AVP is excess. Sustained hypokalemia will happen if the aldosterone is in excess, whether it's primary or secondary. So metabolic alkalosis, use of diuretics, tubulopathies, and RAAS abnormalities will cause a hypokalemia in that situation, as well as osmotic diuresis. So RAAS excess will cause hypokalemia with alkalosis. So how do we evaluate? The most important thing to look at in a child who comes to us with hypokalemia is the pH. If there is metabolic acidosis, everybody with hypokalemia should have metabolic alkalosis. If there is metabolic acidosis, we are dealing with RTA or diarrhea. Then you look at urinary anion gap to differentiate RTA, which is positive, and diarrhea, which is negative. If there's alkalosis, this could be diuretic, Bartter, Gentleman, or RAAS. You look at blood pressure, renin levels, aldosterone, and magnesium. Look at urinary potassium. If your urinary potassium is less with hypokalemia, it's extrarenal. More than 100, it is typically renal. You can also use a urinary potassium to creatinine ratio, which is also there. Serum sodium level, if it's high with hyponatremia or normal, it is RAAS excess. Low, it means that you're losing it either the gut or the diuretic. So this becomes important. So mainly you're looking at sodium, urinary anion gap, pH, urinary potassium, and magnesium level. Very important to look at acidosis, particularly for urinary anion gap. So urinary anion gap is basically the difference between unmeasured anion and unmeasured cation. In diarrhea, because the ammonium production becomes more, we expect this anion gap to actually become negative. While in RTA, because this ammonium production is defective, you expect this anion gap to become positive. So the most important thing to look at in somebody who has acidosis and hypokalemia is to look at urinary anion gap. Positive anion gap suggests RTA, while negative anion gap will suggest diarrhea. If somebody has alkalosis with hypertension, think of RAAS excess situation, look at renin and aldosterone level, and then you can interpret that. And if both levels are low, look at DOC excess situations like CAH variants. If all the things are low, renin is low, aldosterone is low, DOC is low, it is either apparent mineralocorticoid excess syndrome or a epithelial sodium chloride channel defect. These are more complicated issues which we won't discuss too much out here. In this case, you can give a spironolactone trial. So very importantly, when you're assessing for RAAS, best to do a 8 AM ambulatory sample for renin activity along with aldosterone in the setting of normal salt diet and after stopping all drugs. There is a log linear relationship between aldosterone and renin activity. If aldosterone goes low, renin should shoot up. If aldosterone becomes high, it should come down. So if aldosterone is high and renin is low, this is basically a primary hyperaldosteronism. If aldosterone is high and renin is also high, it is hyperreninism in this situation. So effective RAAS excess, you have to basically look at the different situations. If renin is high, it is secondary hyperaldosteronism. If aldosterone is low, it means it's an apparent situation like Cushing syndrome, CAH variant 11 and 17, apparent mineralocorticoid excess and Little syndrome. And looking at further workup, you can decide about the investigations and go from there. Now, if alkalosis is there with normal blood pressure, basically in that case, you have to exclude things like vomiting, NG aspiration, and diuretics. Then you have to look at magnesium level. If magnesium level is low, you're dealing with a number of conditions like malnutrition, Barter's, and Gentleman syndrome. Look at fractional excision of magnesium. If it's low, it is malnutrition. If it's high, it is Gentleman syndrome. And if there is hypercalciuria, it's basically Bartter syndrome. So now if we classify the causes of hypokalemia, if the volume is high, it is RAAS excess. If urinary chloride is low, usually the urinary chloride is high. If it's low, it's RTA or diarrhea. If there is acidosis, it is RTA or diarrhea. If the magnesium level is low, we are dealing with either malnutrition, Bartter, or Gentleman syndrome, and blood pressure will further be able to help us. If the blood pressure level is high with alkalosis, we are dealing basically with a RAAS excess state. So to approach to hypokalemia is basically to exclude the diuretic use, malnutrition, and blood gas. Look at metabolic acidosis. If the metabolic acidosis is there, look at urinary anion gap. If the urinary anion gap is positive, it is RTA. If it's negative, it is GI loss. If there is metabolic alkalosis, look at blood pressure. If it's normal, look at urinary calcium. If it's high, it's Bartter. Low, it's Gentleman syndrome. If the blood pressure is high, look at aldosterone level. If it's high, it is aldosterone excess, glucocorticoid remediable aldosteronism, or a primary hyperaldosteronism. If it's low, it is a CAH variant. If it's not there, then you have to think of Liddle's or AME by giving a spironolactone trial. Response to spironolactone will basically means it's an apparent mineralocorticoid excess no response. Response to amyloid means little syndrome. So the key thing to look at in a child with hypokalemia is to look at blood gas. Acidosis, very simple, RTA versus diarrhea. Alkalosis, look at blood pressure. Normal blood pressure, Barter-Gitelman. Blood pressure is high, look at aldosterone and PRA. And some of those CAH variants you will be able to identify. 12-year-old girl with multiple fractures, failure to thrive, polyuria and myopathy. You see there is metabolic acidosis and hypokalemia. So acidosis, hypokalemia is RTA, fractures 100% RTA. Anion gap is low, so this is a normal anion gap acidosis. So we don't need to do a urinary anion gap here, but just for completion's sake, it was really positive. So this is classical case of distal RTA in this setting. So hypokalemia, acidosis, and a positive urinary anion gap. 3-month-old girl, failure to thrive, potassium is very low and not gaining weight. We find that there is metabolic alkalosis. Blood pressure is normal. So you look at urinary calcium, it's nephrocalcinosis. So this is basically Barter syndrome. So hypokalemia with alkalosis, normal blood pressure, and nephrocalcinosis, Barter syndrome. 8-year-old girl with early puberty, height is 134. There is severe metabolic alkalosis and hypokalemia. Urinary chloride is high. Metabolic blood pressure is high. So there is hypertension with metabolic alkalosis. We're looking at variants for CAH. And what we found that there was actually a cryptorchidism. So this child actually presented as a boy with precocious puberty. But then when we worked up, we found hypertension and cryptorchidism. So this is basically a X6 TSD, which is now presenting with this picture. And this was a 11-hydroxylase deficiency. 14-year-old girl with delayed puberty. And what we are seeing is that there is alkalosis with hypokalemia. There is increased urinary chloride. There is hypertension. So girl with hypertension, metabolic alkalosis, always think of 17-hydroxylase deficiency. In this setting, there were inguinal gonads. So it's again a XY DSD, which is basically presenting like 17-hydroxylase deficiency. So hypokalemia with hypertension, always think of these two CAH variants. Look at puberty, look at the gonads in this setting. 1-year-old boy with failure to thrive, polyuria with hypertension, hypokalemia with metabolic alkalosis. There is renin is low, aldo is undetectable. So basically, we have excluded all the primary causes. We have now looked into the urinary steroid profile, which basically, and there was a response to aldactone. So this is suggestive of an apparent mineralocorticoid excess, which is likely in this case, given that he actually has presented at a very young stage with severe hypokalemia and hypertension. 2-year-old girl with failure to thrive, blood pressure is high, potassium is low, and what we are seeing, renin is low, aldosterone is undetectable. So now we are dealing with two possibilities, either a amyloid related, either AME or a Little syndrome. So what we did, we gave aldactone, there was no response, so this turned out to be Little syndrome. So hypokalemia is most likely related to either a gastrointestinal cause or a diuretic use. But if it's a chronic hypokalemia, early onset hypokalemia with hypertension, or associated with acidosis, we have to think of specific causes in that perspective. We'll finally touch base about hyperkalemia, which again is mostly because of renal causes, but can occasionally be because of an adrenal cause. So again, symptoms of hyperkalemia are associated with the level. So once the level go really high, like above 6.5 points to 7, paralysis can happen. Cardiac abnormalities in the form of wide QRS, ST elevation, and ectopic beats happen beyond 6. Peak T waves are the first one to appear. And finally, sine wave and blocks happen when the level go beyond 8 in that situation. And finally, we can have asystole, which may happen. Hyperkalemia can happen if there is a shift of potassium from inside because of metabolic acidosis, tissue lysis, rhabdomyolysis, tumor lysis, or those situations which can cause that, or insulin deficiency in that perspective. It can also be because of increased intake, very unlikely unless there is a renal failure because of oral or IV potassium salts which are given, or blood transfusion which are containing potassium. Endocrine causes are usually because of reduced renal losses. So beyond renal failure, if we talk about RAAS defect, you will have hyponatremia and hyperkalemia. ACE inhibitors, ARB, spironolactone of course cause that perspective. So evaluation starts of course to exclude renal failure. Very importantly, urea may be slightly high in RAAS defect because of dehydration. Look at urinary potassium. If urinary potassium is high, we are basically dealing with a potassium load. If urinary potassium is low despite hyperkalemia, it means there is a RAAS. There was a lot of word about TTKG and how it should be used, the transtubular potassium gradient as the marker of aldosterone effect. But now urinary potassium or urinary potassium to creatinine ratio is the best marker in this setting. Very importantly, if there is hyponatremia, we are dealing with renal failure or a RAAS effect. Hypernatremia with hyperkalemia is Gordon's. Now, one of the major challenges which one faces in terms of endocrine perspective is to differentiate hyponatremia and hyperkalemia, whether it is renal or adrenal. So if the volume is more, hemoglobin is low, uric acid is basically normal or high in the setting of renal failure, urine output is low, it's mainly renal. While if there is hypovolemia, high uric acid level and the hydration level is basically again, uric acid is high, and the urine output is high, we are dealing with the adrenal cause. And this is very, very important. So for hyperkalemia, you exclude renal failure, drugs and tissue lysis, look at renin. If the renin level is low, it's very rare hyporeninism. If it's high, look at aldosterone. Aldosterone is low, look at cortisol, which is low, then look at the workup for 17-hydroxyprogesterone imaging, and then further workup. High aldosterone, look at pseudo-hypoaldosteronism in this situation. Now, most commonly, from an endocrine perspective, you will be faced with a newborn who comes to you with salt wasting. And this approach is going to be very, very helpful. The first step here is to exclude a urinary infection and obstruction, because that can cause a transient pseudo-hypoaldosteronism picture. Look at the genitalia. If the genitalia are atypical, look at palpable gonads if the palpable gonads are there. So you are talking about a XY-DSD. Look at the HAS level. If it's low, it's star SCC. If it's high, it's 3-beta HSD. If you have got no palpable gonads with atypical genitalia, you're dealing with a X6-DSD. Most common cause is going to be 21-hydroxylase deficiency. 17-OHP very high, 21-hydroxylase. Borderline, it could be 3-beta or 11. Now, if the genitalia is normal and the child is a male, of course, excludes 21-hydroxylase deficiency. If it's normal, exclude adrenal hypoplasia congenita. In a girl, exclude the rarer form of SIADH. If everything is done, look at aldosterone. If aldosterone is low, it is 11-aldosterone synthase defect. If it's high, it's pseudo-hypoaldosteronism. So basically, the evaluation will depend upon the genitalia, whether it is normal or not, whether you have got a normal 21-hydroxylase. In boys, exclude AHC, and then you go with aldosterone levels. 6-month-old girl diagnosed with cystic fibrosis, failure to thrive, chest infection, sweat chloride level on the higher side, no steatorrhea, sodium is normal, potassium is high. So while hyponatremia can happen with cystic fibrosis, you won't have hyperkalemia. This is typical picture of a defect of action of the sodium chloride channel, in which you can have chest infections and high sweat chloride. This is PHA1AR. 1-month-old boy with reduced feeding, birth weight was 3100, now has again only 100 grams, hyponatremia, hyperkalemia, 17-OHP is normal, cortisol is high. So it's not adrenocortical defect. Renin is high, aldosterone is on the higher side. So what are we dealing with? This looks like a pseudo-hypoaldosteronism. But remember that reversible causes like obstruction in UTI can cause a similar picture. So this is a transient form. We found UTI in obstruction. This should always be excluded in a newborn with hyponatremia and hyperkalemia. 1-month-old child with reduced feeding, birth weight, which is again not gained. So again, I think this is a same situation that we're dealing with of a reversible form. 1-year-old child with failure to thrive, irritability, blood pressure is all right. Sodium is high, potassium is high. So high sodium, high potassium, hypertension. This is a typical case of Gordon syndrome. So Gordon syndrome should be suspected in anybody who has hypernatremia and hyperkalemia. Management basically involves the severity of symptoms. So if there are paralysis and arrhythmia are there, you give calcium gluconate, insulin dextrose, precautions of ECG monitoring, and repeat calcium if required. You can also give soda bicarbonate beta agonist, exchange resins, and furosemide. Dialysis should be considered if it's persistent. If the potassium, if there are no paralysis, potassium levels are more than 7, give calcium gluconate, less than 6, stop the incriminating agents, correct the cause. If it's 6 to 7, there is a risk of rise like renal failure. You treat it Otherwise, you go ahead with a conservative measure. So key management depends upon the paralysis, arrhythmia, potassium levels, and underlying condition. And acute management is calcium, insulin, dextrose, soda bicarb, and beta agonist. So we have tried to cover a lot in this 1 hour overall with regards to the electrolyte disorders. Now, this is a challenging talk, a difficult one. We will be posting this video on the YouTube, so you can use it again and view it. And hope we had good interaction. I'll see if there are any other questions. Meanwhile, you can visit our website for further learning opportunities, as well as the master course in pediatric endocrinology, and download our app, which will help in that perspective. So we'll see if there are any particular questions which are there. So Dr. Naraj say how to differentiate between Barter's and pseudo Barter's. So I think that condition is usually, when we talk about Barter syndrome, main consideration is that there are different forms of Barter syndrome. If you have a neonate who has severe failure to thrive, polyuria, metabolic alkalosis, hypercalciuria, nephrocalcinosis, it's Barter. Pseudo Barter is more in terms of the other dehydration which is causing that perspective. About thyroid periodic paralysis, this can happen mainly with thyrotoxicosis, in which there is a sudden channelopathy, the potassium levels goes down. Typically, I have encountered is between 15 to 25-year-old males who consume a lot of glucose or any carbohydrate drink. There is sudden shift, they have a paralysis. The condition is independent of thyroid functions, but tend to improve over time. So potassium level should always be correlated with the ECG changes, because of course you can have, it will take time for the potassium level to come down, and if it's non-reliable, you should always look at the ECG in this perspective. So I think if there are any questions, we can take it now. Otherwise, we can, I think this kind of, we can complete the discussion here. And once again, best wishes for all of you, for health for you and your family, and hope we all come out very positive out of it. We will be posting this video on the YouTube channel, so you can follow it up from there. And meanwhile, I'll thank all of you for patient here. So Dr. Divya has asked just a question the last time. Any time duration for measuring electrolyte? So you can do a spot urine, and particularly we would like the urine to be done at a time when the potassium abnormality or the sodium abnormality is there. Timed urinary sample are not going to be of much help. So I think we'll close at that point of view.